All right, everybody ready? Hi, good evening, everybody. Welcome to CHD Wise, which is a virtual education series hosted by Conquering CHD. My name is Rebecca Acosta, and I'm the education coordinator. Tonight on this episode, I am happy to welcome several doctors and an adult patient. Dr. Ari Cedars is from Johns Hopkins University Medicine, Dr. Eric Krieger from University of Washington in Seattle, and Dr. Marla Mendelson from Northwestern in Chicago. And then we have our adult patient, Jennifer Weiner, who, like I said, is an adult with CHD, and she is also the national ACHD coordinator here with me at Conquering CHD. Just as a quick housekeeping note, everyone who's joining us in the audience is muted during the presentation portion, and you can use the chat feature at the bottom of your Zoom panel to send questions. And once our doctors do their presentations, we'll have a live Q&A for you all to participate in. So each physician has about 10 minutes or so of information they want to share with you on specific topics. And we're hoping to have between 25 and 30 minutes for Q&A discussion at the end of the hour. As another reminder, these are doctors who are volunteering their time and expertise with us. And so obviously they're not your doctors and they can't answer specific questions to your anatomy or your treatment plan. This is more of a general guide and information for you to take back to your care team and discuss specifics with your doctors. So I'm now happy to turn it over to Dr. Krieger, who is going to discuss reproductive health in terms of transition from pediatric to adult care. And then Dr. Cedars will focus on women's health and gynecology, and Dr. Mendelson will be speaking about pregnancy in the CHD patient. Dr. Krieger, take it away.
Thanks a lot, and thanks for inviting us to join in this session. So I'm Eric Krieger out here in Seattle at the University of Washington and Seattle Children's Hospital. I'm going to be talking to you about transition, as Rebecca pointed out. So just as a brief introduction in terms of what transition is, because not every patient goes through a transition process as part of their move to adult cardiology. So all the folks we're talking about today probably had a pediatric cardiologist, and most of them had a pediatric heart surgeon. But as they get older, there becomes the need to transfer care to an adult congenital heart disease group. And the transition process is the process by which patients go from having a pediatric cardiologist to an adult cardiologist. And it's not just a handoff from one doctor to another. Ideally, it takes the shape of a number of meetings with the adult congenital heart disease team, where you go over topics like education, learning about your heart condition, learning about being an adult with a heart condition. And important to today, one of the things that is important to discuss is reproductive health and sexual health as part of that. And one of the reasons I think it's important, because we do know that it is oftentimes an uncomfortable topic to discuss with teenage patients, and not one that many patients are always looking forward to having with a new doctor particularly. But we do think it's important. And just to explain why I think it's important, I'm going to share an anecdote from my mentor, Karen Stout, who's been doing this for a long time. So Karen often will tell the story of a 20-year-old patient with very complex congenital heart disease, multiple prior surgeries, who came into clinic one day with a nice big belly bump and said, "See, Dr. Stout, all my pediatric cardiologists told me I could never get pregnant. And they were wrong. I can get pregnant." And Karen put her hand to her head and said, no, I think what they meant is that you shouldn't get pregnant, not that you can't get pregnant. So it just highlights the fact that communication and education is really important, because the vast majority of women with congenital heart conditions can become pregnant, and can become pregnant safely as long as we plan on it. And pregnancy is a real big stress on the body. And in a lot of ways, it's sort of like going for a jog for 9 months without taking a break. Your heart rate goes up, your heart pumps more blood, you're breathing harder, and it can be a strain on the heart. So before a woman becomes pregnant, we really want to make sure that we've really done a full evaluation and assessment in terms of making sure that the heart is ready for that. Now, Dr. Mendelson is going to be talking to you about this in much more detail, but one of the reasons that we need to talk about pregnancy and transition is because pregnancy is the kind of thing that needs to be prepared for You need to be prepared for it, and your team needs to be prepared for it, particularly in terms of doing a thorough assessment of your heart function. In order for pregnancy to be planned, we also have to think about how we would protect against an unplanned pregnancy or an unwanted pregnancy. So one of the things that we discuss in some great depth during these transition visits is contraception, because the truth of the matter is that most people are sexually active before they're intending or planning on having kids. So the question is, how can we make sure that people can be sexually active and have contraception that's going to be both safe and effective? And for women with congenital heart disease, not every contraception choice is equal. So the reason this is because some forms of contraception, particularly hormonal contraception that contains estrogen, can predispose women to forming blood clots. And certain women with congenital heart disease are much, much more likely to get blood clots than the general population. This particularly applies to women who maybe have had a prior blood clot, women who are taking a blood thinner for that purpose, women with artificial heart valves, women who've had a Fontan operation. All these women are at higher risk for blood clots. So as we're choosing a contraceptive, we want to make sure that we're making a choice that's not going to increase the risk of blood clots. The contraception that increases the risk of blood clots the most is, quote, the pill, that combined oral contraceptive pill that contains a combination of estrogen and progesterone. It's a very effective contraceptive, but it does increase the risk of blood clots. So for many women, that turns out not to be the best choice. Now, that's okay because there are safe options for all women. So condoms are safe and also protect against sexually transmitted infection, but they're not the most effective form of contraception. They have to be used perfectly. They have to be used every time. But even when they're used exactly as they're supposed to be, there's still a higher rate of accidental pregnancies in people who use barrier contraception compared to other forms of contraception. So it's a good option, but it's not necessarily the best option if our number one priority is preventing a pregnancy. There are hormonal contraceptive options that don't contain estrogen, and those can be really, really good choices for lots of women. Those include the Depo-Provera shot. That's a shot that you get every several months in your doctor's office. It's very, very effective. It doesn't increase the risk of blood clots, and it's a good choice for most women. That includes something called a Nexplanon or an Implanon. That's a little implant that usually goes in under the skin on the forearm. It lasts there for several years, and it lets out a bit of progesterone. And that can be another very effective form of contraception that's very durable, very safe, very effective. Another good option is an IUD. IUDs get put in at the gynecologist's office or even some primary providers' offices. They stay in for several years, and there's a number of different brands out there, but they're quite effective at protecting against pregnancy and also don't have much in the way of a blood clotting risk to them. So I just recommend that during these transition visits, it's very important for the young women to talk about, frankly, what their goals are, and then talk to their doctor about the different contraception choices, which ones are going to be best for them, what the best side effect profile is, because all of these do have potential side effects too. So those are the main issues I wanted to address in terms of reproductive health as it relates to the transition visit, and explain some of the reasons why a doctor might be talking about and asking questions about sexual activity and reproductive health during that visit.
Thank you so much, Dr. Krieger. Really appreciate that. I'm now going to toss it over to Dr. Cedars, who is going to talk about women's health and gynecology. Dr. Cedars?
Thanks so much, Rebecca. So I have to admit, when I was dealt this topic, I didn't really know exactly what to talk about. I'm not really a women's health expert per se, but fortunately, there are some wonderful review articles on the topic that I was able to more or less plagiarize, and that I'm going to present in digestible format for you today. So we're going to start with, this is basically nuts and bolts, the types of stuff that a woman with congenital heart disease might deal with on a day in and day out basis. So to begin with, menstruation. So what's different about the experience of having a period if you have congenital heart disease as opposed to individuals who don't have congenital heart disease? Surprisingly, at least for me, there's actually data about this out there. And women with congenital heart disease have a delayed onset of menstruation, usually on average by 1 to 2 years, which is to say individuals who don't have congenital heart disease most likely develop their first period by the age of 12. The average age amongst women with congenital heart disease is just after 13. It seems to be delayed longer among women who have a cyanotic heart disease or more complex forms of congenital heart disease. And in addition, women who have congenital heart disease have a greater probability of never having a period. Some is called primary amenorrhea. And that also is more common among women who have cyanotic congenital heart disease. Not only is the onset of menstruation delayed in women with congenital heart disease, but women with congenital heart disease have a greater probability of having dysfunctional menses, either having difficulties with painful or uncomfortable menses, uncomfortable bloating during menses, heavy menses, or irregular menses. These irregularities are thought to be at least in part attributable to anovulatory cycles, which means a month during which your ovaries have not actually produced an egg. And this, as we'll get to in a second, has long-term implications for overall health. And then it's not surprising, given that many of you probably are on some kind of anticoagulation, be it Coumadin or Eliquis or Xarelto, that when you have menstrual flow, that flow can be sometimes quite heavy, sometimes lasting days at a time, and can lead in certain cases to iron deficiency anemia. Iron deficiency is common in women even without congenital heart disease during childbearing years as a result of regular blood loss with menstruation. And if you're on an anticoagulant, that probability is that much greater. This is a problem in particular for individuals who have cyanotic congenital heart disease or who have low oxygen saturations, because higher hemoglobins are protective, are normal for your circulation when you have chronically low oxygen saturations. And if you have inadequate iron to produce red blood cells, this can adversely affect your kind of overall ability to do the things you want to do. Next, we'll move on to sexuality. And this is, I think, touching on things that Eric said might be touchy and difficult topics to talk about. These are things that probably you should bring up, and talk with your peers about or with your physician about. So women with congenital heart disease seem to have a similar age at which they first engage in sexual activity. However, they seem to engage in sexual activity less frequently thereafter than age-matched peers. And the reasons for this are not really known for certain, but I think this is an area which more work should go into. It seems like women with congenital heart disease may have body image problems as a result of scarring related to surgeries that were done during childhood, or feelings of inadequacy, as if they were unable to keep up with their peers at school, or somehow regarded as the sickly or unusual child in their peer group. Possibly as a result of the psychological impact of congenital heart disease, in combination with this decreased frequency of sexuality, women who have congenital heart disease experience greater rates of sexual dysfunction. And there's data from Germany where they've actually looked at this, and it shows that compared to age-matched women without congenital heart disease, those with congenital heart disease are much more likely to experience dysfunctions in desire, arousal, the ability to achieve orgasm, and obviously analogously satisfaction with sex. But interestingly, they don't experience a greater amount of distress surrounding sex. They just don't seem to get as much of a good experience out of it. And I think that there's the possibility that open discussions with either peers or with providers about specific problems that you're having with your sexual life can actually lead to improvements, recommendations that can lead to improvements with your satisfaction with that aspect of your life. Finally, moving on to later life. I know that Marla is going to talk about pregnancy, but what happens after pregnancy? Eric has alluded to the fact that pregnancy is a stress on the heart, a stress on the entire body. In the setting of congenital heart disease, where your heart already is under stress, has been exposed to a prior surgery or repair, is scarred, what is the impact of the stress of pregnancy on that? And does that have a long-term effect on cardiac function? The answer to that question is, unfortunately, we're not certain. There are some early small studies which seem to suggest that a prior pregnancy may increase the probability of having weakening of the heart muscle for certain congenital conditions. However, more recent data, which I think is actually better because these more recent data come from larger national databases which are not biased in the manner in which they've collected data, seem to suggest that actually women with congenital heart disease can safely get pregnant in the vast majority of cases without any significant long-term implications for their heart function. Now, as women age, we've talked about the onset of menses. Menses will cease. And with the offset of menses, women may experience hot flashes, all of the signs that go along with menopause. And in individuals without congenital heart disease, sometimes for a year or two, hormone replacement therapy will be recommended. Hormone replacement therapy, just for those of you who may not be familiar with it, is replacement hormones, predominantly estrogens, which help you adapt to the fact that your ovaries are no longer producing those estrogens for you. There's been a lot of data that's come out showing that long-term hormone replacement therapy is a liability in terms of predisposing individuals who take it to breast cancer, as well as risk of vascular disease and blood clots. So these are things which we know are more prevalent among women with congenital heart disease, the propensity to blood clotting, the propensity to cardiovascular disease. And so it's generally not recommended that women with congenital heart disease use hormone replacement therapy. Finally, cancer risk of breast cancer, risk of ovarian cancer, risk of uterine cancer. The risk of nearly every cancer is slightly increased among congenital heart disease patients generally. And that may relate to exposure to radiation as a result of the multiple diagnostic procedures that are required throughout childhood and go along with congenital heart disease. But in women with congenital heart disease in particular, the propensity to having anovulatory cycles, which is to say, like I had alluded to in my first section, cycles or months during which your ovary doesn't produce an egg, is connected with an increased risk of uterine cancer long-term. For these reasons, it's important that you stay in contact with the medical community so that you can have appropriate screening for all types of cancer, especially those related to the female genital tract. And that is pretty much all I had for gynecology and women's health.
Great job. Thank you so much. Now I'm going to turn it over to Dr. Mendelson, who's going to speak with us about pregnancy in the CHD patient. Marla?
Thank you, Rebecca. Thank you so much for inviting me to join this today. This is my favorite topic to talk about, and so I could go on for days, but we're going to hit the high points. We've been talking around pregnancy with some very important issues as they relate to transition and overall women's health. So I want to give you a few specifics. There have been studies done that show that many women who have congenital heart disease, even complex congenital heart disease, can have normal fertility, and therefore this is a very important issue for us to talk about. The most important thing that I've learned over the many years of taking care of pregnant women with congenital heart disease, who basically walked into our office at 22 weeks and we just took care of it. And that's not the optimal way to take care of patients. The optimal way is to evaluate women while they're contemplating a pregnancy and have a very careful planned pregnancy. Because pregnancy does offer a lot of risks to their existing heart disease. It can change their functional status. It can change their longevity. It can change their heart function. But so it's important to evaluate women before they contemplate a pregnancy. That's ideal. And when we do that with preconception evaluation, we want to see how people are as far as their natural history and their unnatural history. How are they doing after surgery? We have learned in the adult congenital heart world that a lot of times there are problems that we can predict at 5 years, 10 years, 15 years. And oftentimes women may have eluded medical attention, and when childbirth becomes an issue, that's when they return to medical follow-up. Obviously, the transition programs are trying to alleviate that problem, but we still face that in reality. The preconception evaluation has to look at functional capacity. How good shape is a woman in? I have a woman with very complex congenital heart disease who has a systemic right ventricle, and yet she runs marathons. Far be it from me to tell her she couldn't have a pregnancy. We want to look at the medications. The right answer when a woman discovers that she's pregnant is not to stop all the medications, but maybe to change her to medications that will serve her heart and yet be safer for her and her future baby. We always tell people that we can get people through a pregnancy, but the hardest thing about having children is really the next 18 years. And so we want to make sure that people are in good shape to run after their kids besides just having them. We discuss all of the different risks at that time, including a risk that a woman with congenital heart disease may confer the risk of congenital heart disease to her offspring. That the numbers are somewhere between 4 and 10%, but we don't, and it's not a reason to discourage pregnancy. We still encourage people to consider pregnancy, but we always do a fetal echocardiogram of a woman at 22 weeks to look at the baby's heart, not to alter the course of a pregnancy, but if there's a problem, we know what to do at the time of delivery. It's also important, and I tell this to my young male patients, and they kind of looked at me kind of strangely, is that dad too can confer that risk. And so for a young man, 21 years old, who's not thinking about having children, but we sort of plant the seed and tell him that someday when you're having a family, your partner is going to have be checked because you do confer that risk of congenital heart disease to your offspring. So those are important, preconception issues. Now, pregnancy itself can affect the congenital heart disease. For example, as Dr. Cedars alluded to, sometimes in a woman who has a systemic right ventricle, the volume load of pregnancy may overstretch the heart and it not return to the way it was before. This is very important, and this is why we watch patients very closely during the course of a pregnancy to make sure their weight gain is reasonable, that they're not overdoing the salt and water retention, and to actually take care of problems early on. We can do diagnostics during pregnancy, and our main diagnostic is echocardiography, but we do not withhold any diagnostic treatment just because somebody is pregnant, with the exception of nuclear studies. So if we need to do a study during the course of a pregnancy, we take all the care, we do abdominal shielding, what we need to get that information. Just because somebody is pregnant doesn't mean we're not going to take care of them fully. The other fact where congenital heart disease can affect the pregnancy itself is that if mom is cyanotic, she may have she's at risk for having smaller babies, and smaller babies have more complications. So these are the things that we have to look into and watch women very carefully. We had a bad example during a pregnancy where they didn't realize that the mom was living at a higher hemoglobin of 16 or so, and so when her hemoglobin fell to 10, which is often seen during pregnancy with the dilution of the extra volume of pregnancy, nobody realized that she was actually profoundly anemic. And that was actually due to endocarditis. So this population is at risk for endocarditis, and maybe, although there's no data to support it, there may be an increased risk during pregnancy, but the important message is to be vigilant about it. And then the last issue that I want to talk about is that we manage pregnancy expectantly. There are WHO guidelines for how Actively, we manage pregnancy and where pregnancies should be managed as far as high-risk centers. We work very closely with our maternal fetal medicine colleagues at Northwestern. And then as far as delivery, and this also comes up in the conversation for preconception, is delivery. Women have been told, A, that they can't get pregnant ever, and B, whenever they get pregnant, they're going to have a C-section. And that may not be true. In fact, in most cases, we prefer a vaginal delivery in women with heart disease because it is faster, there's quicker recovery, less blood loss. But certainly any woman could, who's cleared for pregnancy could have a surgical delivery if that is indicated by obstetric measures. There are a few instances where we might recommend a C-section for cardiac reasons, but it's very, very rare. We also believe in good pain control at the time of delivery because pain causes tachycardia, and that could be problematic in a woman with heart disease. And then lastly, the important thing that we tell all of our trainees is that when you're in the delivery room and somebody has the baby and the baby comes out and they count all the fingers and toes and everybody heaves this sigh of relief, that our job is not over, because all of this increased fluid that has accumulated over the course of the pregnancy has to be eliminated. And in a woman with impaired heart function, that may be difficult. And so a lot of times it's a heartbreaking decision, but we have to tell people they have to be monitored in the unit so that we can watch them very closely while they're getting rid of all this fluid to make sure it's safe and they don't get into heart failure after the course of delivery. Those are the main issues I wanted to touch on, and I'm certainly happy to answer any questions. Thank you.
Thank you each so much for your presentations. I realize it was quite a I gave you to summarize things in 10-minute chunks, but I really appreciate it. And so hopefully that the people that are on in the audience will start asking questions, but I'm gonna turn it over to Jenny, who's gonna moderate those, and I think she has the first question. Jenny?
Yeah, thank you, Rebecca. Yeah, I had a few questions while I was listening to you guys give your presentation. My first one would be for Dr. Krieger. I wanted to ask you, well, two things really. At what age would you recommend patients and their families start to talk to their providers about these questions? And what would you recommend for male patients to ask their providers regarding their reproductive health?
Yeah, thanks. So transition should start early. Most people don't switch from pediatric to adult cardiology until about 18 to 21, but transition starts much earlier than that, maybe 12 or 13. In terms of discussing reproductive health and sexual health, just like sex education in schools begins before kids are sexually active, conversations about reproductive health should begin early as well. You, of course, need to be careful about doing it in age-appropriate ways and culturally appropriate ways that aren't going to be off-putting to either the patient or the parents. But I think these conversations should start early, early adolescence. In terms of what comments I would give regarding males, I think Dr. Mendelson raised a really important point, which is males pass along congenital heart disease just the same way that women do. So being aware of that and understanding that there'll be some need for prenatal counseling and fetal echocardiography during pregnancy. I think also, as Dr. Cedars was talking about some of the medications and their side effects, it's important to recognize that some medications that we use can also have side effects for male sexual health too. Beta blockers, for example, which are really commonly used in heart disease, are well known to cause erectile dysfunction, so that's important. Decreased libido is an important issue in men as well as women with congenital heart disease. And then there's some interactions as well. Some of the medications we use for pulmonary hypertension have potentially deadly interactions with some of the drugs that we use for heart conditions. So an example would be sildenafil, which we use for pulmonary hypertension, really can't be combined with any form of nitroglycerin. That's not a super common drug to use in folks with congenital heart disease, but just to be aware of some of those issues as well.
Great, thank you. Dr. Cedars, did you have anything to add possibly on male reproductive health as well?
Well, interestingly, males with congenital heart disease don't seem to have the same hangups about their physical appearance that females with congenital heart disease have. I suspect that'll come as a surprise to probably no one on the line right now. My guess would be that there probably is a high prevalence of erectile dysfunction. To be certain, that goes along with vascular disease, and it's a common side effect from many of the cardiovascular medicines that we employ and that are used in people with congenital heart disease, whether they're diuretics, beta blockers, ACE inhibitors, although guys act tough, they're really just hiding stuff. So, in fact, the tougher we act, the more fear we're hiding. And so probably I suspect that the machismo does reveal an underlying sense of psychological kind of fear. And so I think that making sure that male patients feel good about themselves and feel confident is probably just as important as it is for females. I was kind of halfway joking at the beginning.
Thank you. Dr. Mendelson, I had a question for you. We talked a little bit about today that just because a woman can physically get pregnant doesn't mean that she should. But what if a woman physically can't get pregnant and they have CHD? How might their CHD impact fertility prevention?
That's a great question. We've come up to this issue in a lot of different ways in our clinic. Fertility is a difficult issue, and certainly we would want to see a woman before she started fertility treatments, because some of the fertility treatments that are used can cause fluid retention, and that could be problematic. There are women who are concerned about carrying a pregnancy because of their risks, and they don't want to rock the boat with their heart disease or take on the additional risk that we've been talking about, being pregnant on high-dose anticoagulation, those type of issues. They feel they need to stay on their medications. And so with those women, we talk about egg harvest. Because with egg harvesting, it is a procedure and there may be a little bit of hormonal manipulation, but women can continue their medications during that. And then they have their eggs harvested to be used with in vitro fertilization, and then they use a surrogate. And we've had several patients that have gone that route. We try to be creative and talk about different options, because there's a lot of different ways for people to become a parent. We've also then had a lot of papers cross our desks to certify that somebody is healthy enough to adopt a child, and we tried again to facilitate that. So not everybody needs to get pregnant to have a family, and we look at different options for that. We work closely with our reproductive endocrinology departments, and we've had good luck with a Fontan woman who's had 2 surrogate pregnancies. And we think it's important to explore all of these options, because it's in the preconception consultation when we tell a woman that I'm concerned about this, and there's been very few times when I've said that, but there have been times when we said this is not a good idea. We need to be able to offer alternatives and how they can be done safely to have a family.
Okay. And then maybe a question for all of you. Is there a specific provider that you would recommend women or men to see should they be considering starting a family? Any specialist that you would recommend, that you would refer them to before they get started?
Well, I think we should do the adult congenital group should be able to do the preconception evaluation for the woman, but also talk to them about seeing genetics, because of syndromes that may be, genetically determined, and high-risk OB. We also have them see, we have a preconception consultation with the high-risk OB maternal fetal medicine group. Also, again, so they can weigh in about different issues. And I think it's important for a couple to get as much information and facts as they can, because ultimately it's their decision.
I think That is a good answer. I think that, it's important that you get talk to a cardiologist if you're a woman or a man. We actually should be counseling patients about this pretty much at every visit. We see patients annually, just to kind of remind you what the land is in terms of probability of passing on congenital heart disease if you're a man or a woman, and then your likelihood and safety in getting pregnant if you're a woman.
Dr. Cedars, I had another question as well about the menstrual cycle for women. You talked a little bit about menopause, and I was wondering, in your research, have you found that prematurely experiencing menopause is something that is common among women with congenital heart disease?
Yeah, I did say that premature ovarian failure is not uncommon in women with congenital heart disease. I did not see, and take this with a grain of salt. This is not my area of expertise, but in the little bit that I read and preparing for this talk, I did not see any evidence to suggest that certain conditions are more likely to experience premature ovarian failure than others. But again, there may be data out there that I'm just unaware of.
Thank you. Speaking very generally, I know we can't give specific information about certain defects, but are there certain issues that you would say preclude a woman from having a safe pregnancy?
Yeah, well, Dr. Mendelson, you can speak to that. Sure, there are some for sure. Eisenmenger syndrome, or anyone with severe pulmonary arterial hypertension, really shouldn't get pregnant. We wouldn't say they couldn't be parents, but they shouldn't become parents through pregnancy. That's the most absolute. There's other very high risk conditions, like some folks who have Marfan's and very dilated aortas that are really approaching the need for replacement. And then generally speaking, women who have congenital heart defects that need to be fixed and still haven't been fixed. So if you have severe aortic stenosis, particularly if it's symptomatic, severe mitral stenosis, particularly if it's symptomatic, if you have congestive heart failure, particularly if it's symptomatic, these are issues that need to be addressed prior to pregnancy. These can be quite dangerous going into pregnancy. Then there's a big spectrum of risk, from things that are really quite safe, like repaired atrial septal defects and repaired ventricular septal defects, to things that are usually safe, like repaired tetralogy of Fallot, to things that are often safe, like patients with bioprosthetic heart valves. And then we have things that really need a very careful conversation, things like mechanical heart valves. We can usually manage a safe pregnancy with mechanical heart valves, but we need to recognize the considerable risk there. And, we can't go into all the conditions, but there is a spectrum, and all adult congenital heart disease doctors are familiar with where all the different conditions fall on the spectrum. So I would recommend that any woman who's considering pregnancy schedule a visit specifically for the purposes of talking about the risk of the pregnancy. It shouldn't be shoehorned into another visit where you're going over your echo and checking in for the year and doing everything else. It's too big a conversation and really deserves probably an hour on its own, or at least half an hour on its own, just to talk through it.
Okay. How about genetic testing? Would you either of you, any of you, recommend a family, either the wife or the husband or the partners, would you recommend they get genetic testing done prior to pregnancy?
I think
I offer it.
Oh, go ahead, Ari.
Go ahead.
I think it depends upon their own issue, and if they have a genetic syndrome. But we're learning a lot every day about this. We've had some families where both parents have had a variant of a bicuspid aortic valve, which they didn't really know about before they started having kids. So I think it is helpful to identify any syndromes. And again, we can't leave the male partner out of this, out of the equation.
What advice would you give to patients and families if their provider isn't comfortable discussing these topics with their young teens?
I think that I would recommend that they seek advice from a provider who is comfortable discussing these things with young teens. I think that being informed is really the best defense against adverse things happening, unplanned pregnancies, which may be plagued by difficulties. All the things that Marla and Eric brought up go into a healthy pregnancy require that pregnancy be planned. The only way that oops babies are avoided is through effective counseling.
Thank you. That's all the questions that I had.
I was just gonna say, I don't see anything in the chat. So audience, you've got another minute or so before we end to throw in your questions. But we know that a lot of people will be watching the recording of this later on. And so if you have questions that you'd like to see us covered in a future topic or to follow up with your provider team, you can always email us at chdwise@conqueringchd.org. And we can either connect you with the right physicians or direct you to resources that can help you on the conversations with your care team specifically. So I'd like to really take this moment to thank you all for joining us tonight. I know it's the evening for everyone and you're on your personal time after a long day in the clinics. I really appreciate it. And I want to make sure everyone in the audience knows some more about some adult resources that we have here at Conquering CHD. So definitely check out our website. As I mentioned at the top of the hour, Jenny Weiner is our National Adult Congenital Heart Disease Coordinator, and she has some amazing resources on our website for teens with the transition checklist, which is interactive on our website. They can use it on their phones. The guided questions tools for teens and adults, and then also a parent version for pediatric patients. We have several guides to ACHD care, whether you're a parent of a young person or an adult living with CHD yourself. And then one of the most exciting things I think is the great supportive network that Jenny and her team have built through online support groups on social media. I think there's up to 600 people now in the group, and they have weekly chats for adults and then special ones for teens only, so they have a safe space to really dive in. As we know, it's a hard go. Those years are tough anyways, and when you're living with congenital heart disease, it's nice to have a place to land. So make sure to visit us at Conquering CHD and check those resources out. It looks like we have one last question in the chat, Jenny, if you wanted to throw that one out there before we wrap up.
Sure. There was a question about age. Is there a cutoff age that you would recommend for women to stop trying to get pregnant with CHD?
I think it really depends on their underlying type of CHD and their clinical status, and I think that's a more important thing. I know that there used to be some mythology about getting pregnant younger, but that would be just before things start changing as far as the natural history. So it's really important. There was one point I didn't get a chance to make, is that we do the preconception evaluation before a pregnancy, and even if that pregnancy was very successful, we also ask that they come back and do another one before a subsequent pregnancy, because every pregnancy is very different and there may be subtle changes that have occurred. So we don't like to make a strict age cutoff. There are weeks in my pregnancy clinic where everybody's over 40, but we certainly need to make this decision on a very individual basis.
There's a question in the box about hypoplastic left heart syndrome as well. Yeah, we've absolutely had women with hypoplastic left heart syndrome have successful pregnancies. That's one of the conditions that results in the Fontan operation. So it's one of the heart conditions where we would want to do a really careful pre-pregnancy evaluation, because anyone who's had a Fontan, it's not a low-risk pregnancy, but we regularly take women with Fontan circulations through pregnancy. But you do want to make sure that women are healthy going into the pregnancy. It's a condition where you might rather, it depends on the individual, but you might rather be pregnant at 25 than 42 with hypoplastic left heart syndrome. And that's another important thing to plan for, just because some of the physiology might be a little bit better at a younger age with that condition.
Thank you very much. I think that's all the questions in the chat.
Yep, that's all I'm seeing. So once again, just thank you guys so much for your time. I'm hopeful that we'll have lots of follow-up once we post this across our networks tomorrow. And we just want to remind everyone that, this is general information overview, that we really want patients and families just to be educated and have these little nuggets of information to take to their care teams and talk about specifics for their disease and their defects with their care team. And the last thing I'll mention before we sign off is that at Conquering CHD, we're really proud to present these educational opportunities and resources for patients and families and caregivers free of charge. And we really rely on generous donors to make these things possible. So if you're ever interested in giving us a little help, visit us at conqueringchd.org and click on donate. And those funds will help us continue great programs like this one. So again, thank you so much for joining us. And if you are watching the recording, we'll see you next time. Thank you all so much. Night.
Night.